enlarging mass compression. This case highlights the complication of an unexpected difficult intubation and the use of a stepwise approach in decision making for proper airway management. This is a case of a 62-year-old female who presented with difficulty swallowing. She was prior to admission with an appearance of a left submandibular mass and a weight loss of 5 kilograms. This prompted consult, leading to admission for medical workup. Past medical and family history were unremarkable. She worked as a street sweeper for 35 years, as a known smoker, with 7 pack years up until 2 months prior to admission. Physical exams under the neck shows a bilateral palpable, hard non-tender, and non-movable submandibular measuring 4 by 4 centimeters on the left and thighs on it. She is as a classification 2, Malampati score 2, with a thyromental distance of 7 centimeters. The following are the laboratory Malampati score 2, with a thyromental distance of 7 centimeters. The following are the laboratory results done during admission. She was admitted with a diagnosis of neck mass to consider the following: abscess, thyroid cancer, lymphoma, and extrapulmonary tuberculosis. The patient underwent radiologic exam, initially diagnosed with Cox infection, and started on TB treatment via NGP. However, the main service had difficulty inserting one, hence she was scheduled to undergo the following procedures: EGD under sedation, EGD-guided NGD insertion, possible open gastrostomy tube insertion, and excision biopsy of the left cervical mass. The plan was for her to undergo general anesthesia and endotracheal intubation, with preparation was 8 hours fasting with no preoperative medication. She was pre-oxygenated and inducted with the following medication. An initial attempt at intubation using Macintosh Plate 4 was done. However, difficulty visualizing the glottic opening was experienced. She had a Cormack-Meehan classification of grade 3, so pocket pressure was applied, but this failed to help visualization. A second attempt was done, and a 7.5 tube was successfully inserted. However, the EGD was aborted due to difficulty inserting the endoscope because of a fungating friable mass at the esophageal opening. The surgeon proceeded with doing the open gastrostomy and the incision biopsy. She was then brought to the ICU after for close monitoring for aspiration precautions prior to extubation. Histopath confirmed the diagnosis of squamous cell carcinoma, fully differentiated and metastatic. On the 13th hospital day, 10th postoperative day, the patient experienced sudden expiratory wheezing and increased sensation of esophageal obstruction. On the 14th hospital day, she was unable to tolerate the supine position. Despite treatment with hydrocortisone, Combivent nebulization, the symptoms persisted. An ABG yielded the result of respiratory alkalosis, and the worsening condition of the patient prompted intubation at the wards. However, despite several attempts, they were unable to intubate, and she was brought to the operating room for the procedure with a double setup for a tracheostomy. At this point, a high suspicion of airway obstruction or tracheal stenosis prompted the decision of doing a tracheostomy instead. At the OR, she was with exertional dyspnea and audible stridor. She was on face mask with oxygen supplementation of 2 to 3 liters per minute with an oxygen level at 98%. The patient was inducted with the following medications, and she was easily ventilatable with no episodes of desaturation during procedure. This shows the extent of the tracheal invasion done using a visual laryngoscope during procedure. It shows a narrowed slit-like tracheal area. The patient was under 24-hour surveillance at ICU before transferring back to the wards. She was then referred to radiation oncology for CT simulation and therapy, both of which were not done due to financial constraint. She remained at the ward hemodynamically stable until the 42nd hospital day, when she experienced hematemesis and hypotension, at which she expired. Head or neck mass presents a challenge for anesthesiologists because of the possibility of a difficult airway intubation due to an altered anatomy secondary to mass effect. Squamous cell and adenocarcinoma represents more than 90% of esophageal cancer. Obesity, gastroesophageal reflux disease, Barrett's esophagus, alcohol, and tobacco use are risk factors. Our patient presented with some of the usual symptoms, such as dysphagia, alinophagia, hoarseness, cough, and dyspnea. Up to 25% of esophageal cancer involves adjacent structures of the bronchus, trachea, and aorta, inducing airway obstruction, compression, or via direct invasion due to an anatomical position of the tumor. The signs of stridor, dyspnea are usual indications of upper ear pathology or stenosis. In this case, the diagnosis of cancer was confirmed via a biopsy. However, no radiologic assessment was done to confirm the extent of the mass. The rapid increase in size and alteration in anatomy brought about by the mass was a complication not immediately expected. Difficult airway is when a conventionally trained anesthesiologist experiences difficulty with face mask, tracheal intubation, or both. The possibility of not being able to ventilate once sedated may lead to morbidity or even death. A simple structured approach is highlighted by the American Society of Anesthesiologists' difficult airway algorithm, with emphasis given on the recognition of a difficult airway and a decision to find alternative techniques. This includes deferring the procedure or doing an invasive approach similar to our case. The United Kingdom's Difficult Airway Society also recommends limiting the number of airway intervention to 3 attempts plus 1 for a more experienced operator, especially if a blind technique is used. The following are the usual techniques utilized. As a recommendation, preoperative assessment, history taking of previous medical procedures, intubating history, and key airway features are vital information needed to be documented. Radiologic examination is also a beneficial tool. Difficulty in intubation is a common problem in general anesthesia. It is up to the anesthetist to have a preformed plan in this scenario through a thorough knowledge of alternative techniques. So good thinking and a good judgment is paramount to achieving the goal. The floor is open for your questions.
So you were already anticipating a difficult airway for the third time because time you tried inserting a 6.5 and then get in.
Actually, ma'am, the second time at the wards, only a bougie was used to try to insert.
Was the patient sedated during that
No,
time?
ma'am. It was done with local anesthetic, local sprinkle.
So which means even the bougie won't get
Even
in.
the bougie, ma'am.
Okay. Now, during the attempt at the operating room, were you not worried that giving such a kind of deep anesthesia would compromise your airway?
Actually, we were contemplating it, but at the wards prior to transfer, she was put on face mask at 3 to 4 liters per minute, and her O2 saturation didn't fall below 98. So we were thinking that there was an airway, may patent opening from it.
Yeah, it's different for an awake and anesthetized patient because why did you not consider an awake or as a mildly sedated tracheostomy?
At that point, the patient's speech was already nice. We wanted to relax the patient a bit, just to slightly sedate the patient, and sevoflurane was given at 1 week. Just
No, you gave fentanyl 50 mics and midas of 2 milligrams.
one initially got prior, and when she was able to tolerate it with no episodes of desaturation, and then during the procedure.
I would like to advise you next time that when you write a paper, do not just put abbreviations
Yes.
because you use EGD, and in our institution we do not use EGD. So you didn't even write that, you didn't even put it down with the meaning of EGD.
No, then, ma'am. Sorry.
Okay, so, yes. Yes, Dr. Arnel.
it.
Before you started the sedation for, I call it video gastroscopy. In our institute, is video gastroscopy. Before you did that, what did you prepare for the airway?
For the airway, there was different sets of ET tubes, and laryngeal mask airway was also on hand, and the video laryngoscope was also there.
What was your video laryngoscope?
It's a Viditrac.
Mahirap din gamitin yun.
May learning curve, ma'am. Actually, there is a learning curve, but since we use it often in our institution, so we do have a good grip on how to use the Viditrac. Thank you.
So you did AGD. Ano bang ibig sabihin ng AGD na yun? Hindi ko alam.
The gastrodiadonoscopy, ma'am. Sorry.
You know, even with the insertion of your NGT, there was difficulty.
Yes, ma'am.
So you would expect difficult airway right away.
Yes, ma'am.
Do you think putting an LNA there would work?
It was a backup at that point, ma'am. So,
Did you give it a try to put an LNA
no,
on
ma'am.
this kind of patient? Why?
Because it might not be able to fit properly due to the mass without any knowledge of how they exercise the mass.
Thank you.
Thank you, Dr. Panagiban, and thank you, judges, for the questions. Now we proceed to our ninth presenter. We may present Dr. Ernest Victor Yao Shumacera to present anesthetic management of a super obese patient with trisomy 21 Down syndrome for emergency exploratory laparotomy, possible biliary surgery with common bile duct exploration with intraoperative cholangiogram at Kaiser. Give him a round of applause.
Hello. Hey, test. Good afternoon. The difficult airway is one of the most important challenges to an anesthesiologist. Despite all the recent advances in airway management, in a retrospective study of more than 6,000 patients saw a difficult airway, wherein 56% of which were not recognized by the attending anesthesiologist. I am here to present the anesthetic management of a super obese patient with trisomy 21 for emergency exploratory laparotomy, biliary surgery, and common bile duct exploration. We aim to discuss the successful anesthetic management of this case with emphasis on the airway management of this difficult obese airway. A 30-year-old female was referred to our service for an emergent abdominal surgery. On pre-op evaluation, we were surprised to see a 125 kilogram lady standing 1.42 meters with a computed BMI of 61.82 kilogram per meter squared, classified by Lakin et al. As super obese. On further inspection, she was jaundiced, had slanted almond eyes, mid-facial hypoplasia, a receding chin, very short neck, large submental fat pad, and with macroglossia and with copious amounts of oral secretions. The thyromental distance was 3 centimeters, mandibular length was 9 centimeters, and mouth opening accommodates 3 finger breadths. The neck circumference was 49 centimeters with noted midline trachea and good neck mobility. The stop bang score for this patient was 4 out of 8. She had clear and equal breath sounds. Her abdomen was soft, not distended, with an abdominal girth of 188 centimeters. The intervertebral spaces were not palpable due to the thickness of fat over the back. Ancillary workups were all normal. Just a radiograph revealed an elevated right hemidiaphragm, probably positional in nature, and abdominal ultrasound revealed caudelithiasis. Down syndrome is a congenital condition most often associated with a difficult airway. Occurring in 1 out of approximately 700 births, it has a high genetic complexity and phenotype variability, often manifesting with varying degrees of obesity, cognitive impairment, and multiple congenital abnormalities. Majority of patients with Down syndrome suffering from obesity also presents with obstructive sleep apnea and difficult airway. Obesity comes with adverse health implications of multiple organ systems, most notably hypoxemia and hypercarbia, even with modest sedation, high perioperative cardiovascular complications, and the risk for aspiration. Subglottic stenosis is a feature of Down syndrome with an incidence rate 10 times that of the general population. If present, it would necessitate the use of a smaller endotracheal tube to be inserted. A smaller caliber tube, however, would result in increased airway pressures during ventilation, limiting the delivery of adequate tidal volume, consequently leading to carbon dioxide retention and narcosis. Presented with the salient features of this case, we were in a quandary on the appropriate anesthetic and airway management for this patient. The dilemma would be general versus regional anesthesia. Although regional anesthesia offers a high safety profile in terms of providing anesthesia in obese patients, it entails proper positioning, cooperation, and palpable landmarks, all of which were almost impossible to achieve because of our patient's physical stature, mental age, and level of cooperation. Since obese patients are at risk for Mendelssohn syndrome, we immediately started her on aspiration prophylaxis and venoclysis was started. We have decided on doing general anesthesia and general endotracheal anesthesia based on our evaluation and consent from the patient's parents. We prepared options for difficult airway management, and our priority was to make sure that even in this difficult case, we have a secure. Upon arrival in the operating room, the patient was hooked to ASA standard 2 monitors. Her vital signs were as follows. Metazolam was given for anxiolysis. Atropine was given as an anti-patient's mean body weight. The level of anesthesia was deepened by sequentially increasing the concentration of sevoflurane without obliterating spontaneous breathing. After ensuring adequate depth of anesthesia, we inserted an LMA fast trap. The LMA fast trap was used both to secure the airway and subsequently as a conduit for fiber optic bronchoscopy in our investigation for subglottic stenosis. After confirmation of the absence of subglottic stenosis, we deemed that an endotracheal tube size 7.0 would fit. This was confirmed by a bronchoscope through the LMA fast trap, after which the patient was then paralyzed with rocuronium 0.3 milligrams per kilogram. The intraoperative period was unremarkable, lasting for 225 minutes. The blood loss was 500 ml, and 2 hours from the last dose of rocuronium with spontaneous patient breathing, Sucamadex 2 milligrams per kilogram was given, with noted adequate exhale tidal volume and regular rhythm of thoracic breathing. The endotracheal tube was removed. However, the LMA was left in place, serving as an oral airway until she voluntarily cuffed the LMA. The patient was transitioned to the recovery room with intact airway reflexes and comfortable with the following post-operative analgesics. Up to this time, our patient's difficult airway was continuously in the capable hands of our anesthesia team. In conclusion, the management of patients with Down syndrome, especially the super obese with difficult airway, starts with proper planning and preparation for expected physiologic changes, possible complications, and unexpected situations. The use of LMA Fast Track in this case proved to be effective in establishing a secured airway prior to intubation, and also as a diagnostic adjunct by acting as a conduit for fiber optic bronchoscopy in the investigation of subglottic stenosis. Thank you for listening.
Thank you, Dr. Chumacera. Okay, the floor is now open. Judges, for your questions.
I congratulate you for
It was given to reduce the risk of gastric aspiration for our patients.
what is the mechanism of action? When you use it, you should know the mechanism of action. Why do you call it a gastrokinetic agent? In fact, metoclopramide in America belongs already to the black box. Hindi na ginagamit yan. It is a very poor anti-emetic drug. But I want you to tell what the mechanism of action is and why it should work. Ito ginagamit.
Great on that.
You better read on that, doctor.
Yes, doctor.
You are very fond of your metoclopramide. You can prevent any adverse effect by not use. Why you should not use it? You have to know why.